First of all, thank you all of you for participating today. Happy New Year to everybody. It's glad to see that we have so many participants in the first week of the year. And today, Dr. Junkins, that again is our director of microbiology here at Norton Healthcare, and he's a member of our team here at the Norton Infectious Diseases Institute. Is going to give us an update of a topic that is so relevant for this time of the year, bacterial pneumonia. I thought I was simple, but I can see here that it's not that simple. Alan, thank you for your time, and the floor is yours.
Well, you might think it's simple. And honestly, I thought to myself, why do I want to talk about pneumonia with Dr. Ramirez listening? Because, he's Mr. Pneumonia. But I'm going to complain a bit about how difficult it is from the microbiology perspective. So we'll see how it goes here. First of all, just some numbers here. Of course, pneumonia is a big deal. Almost 50,000 people died in 2020 from it. This is data from the National Center for Health Statistics. Used to be the number one, pneumonia flu, the number one infectious cause of death in the United States. That's not been the case since 2020 because it has been overtaken by COVID. But it's still, pneumonia hasn't gone down. I did think this was interesting. I kind of threw this in here. This is different data. This is from the Institute for Health Metrics and Evaluation, which is based at the University of Washington. So if you look at the left side, shows you the United States, and they're saying there's 80,000 people who died. I guess per year, I guess that is. I guess I didn't really look at these graphs too well. But in the United States, you can look at this and see that it's those folks 70 or older who make up the great majority of deaths from pneumonia. And you can see there's the death rate as well. I thought this was interesting over here, though. If you look at the worldwide picture, the big happening that's gone on over the past 20, 30 years has been the huge decrease in the death rate in children under the age of 5, really come way, way down from what it used to be. And you can see that up here, the number of deaths. It used to be in 1990 that the majority of deaths from pneumonia worldwide were in children under the age of 5, but that's not the case anymore. So I just thought that was kind of interesting. All pneumonia is not the same. The thing about pneumonia is you got all kinds of different categories of it. There's community acquired, there's hospital acquired, there's healthcare associated, and all of you who are in infection control, I'm sure you know all of that and have all the definitions memorized as far as what is what. But you also have very acute pneumonias that come on suddenly and are very intense, and you have some that go on for days, weeks, years. You have adult, pediatric, not necessarily the same thing. You have all kinds of patient factors that come into play as well. And then, of course, there's a whole range from basically asymptomatic all up to very intense, severe pneumonia. From a lab perspective, I kind of look at it and say, obviously, we're going to have bacterial, fungal, viral, and microbacterial. And then there's a whole bunch of different specimens that can be collected from the respiratory tract that can help us do this. But I'm going to say this, the laboratory does not diagnose pneumonia. That's not our job. We don't do it. I kind of think other infections, we do make the final diagnosis. But in pneumonia, it's really the physician doing a physical exam and looking at chest x-rays that figure out this patient has pneumonia. The laboratory is not needed for that. Now, there are laboratory tests that come into play when you start looking at grading the severity of pneumonia. These are the criteria for severe community-acquired pneumonia that's out from the IDSA. And you can kind of see, obviously, there's lots of lab tests that are involved in figuring out whether it's a severe pneumonia or not so severe pneumonia. So the laboratory helps in that. But when it comes down to finding out what is causing the pneumonia, that's the job for the microlab. And there are lots of different tests that can be done to figure that out, not necessarily all of them in microbiology, but there's lots of tests that can be done. Now, one of the things we've talked about, I think, 2 or 3 times now in these presentations is the kind of the history of microbiology testing and how we've seen where a lot of things have gone from culture that got replaced sometimes by antigen testing, and that then got replaced at some point by molecular analysis, so that we're all kind of doing molecular now instead of in culture. When it comes to pneumonia, what I would say there is not so fast. We really have not replaced culture with molecular yet for pneumonia. You can see here I put no next to viral culture. Viruses, yes, viral culture has pretty much been replaced with PCR and other molecular tests. But for bacterial pneumonia, that's not the case. For bacterial pneumonia, we still look at the sputum culture. And so I'm going to spend a good bit of time here talking about the sputum culture. First of all, and one of the reasons I want to do this is because I really look at it and say, this is probably, in my opinion, and notice this is just my opinion, the most difficult type of culture that we do. Difficult in terms of figuring out what it really means. It relies very heavily on the lab staff to look at those plates and to make an interpretation of what it means. And as I hope I'll show you here in a little bit, sometimes that's easy, sometimes that's very difficult to do. It's a tough culture. So here's some problems with sputum culture. First of all, most people out there in the real world do not know what a sputum is. If you give 100 people a cup and say, I need sputum, you're going to get 95 containers that contain spit, because spit and sputum kind of sound similar, don't they? So most people, that's what they're going to do. That leads us to problem number 2. This is a list here of the most common causes of bacterial pneumonia. I'm going to talk just bacteria now. We'll ignore the other things for right now. But for typical bacterial pneumonia, these are your most common causes. The problem with this is that all of these ones, highlighted in orange, are also normal flora of the upper respiratory tract. So if you're going to collect a sputum, comes from down in the lungs, it comes up through the mouth, it can pick up all these normal flora bugs on the way out. So when I get a culture that contains strep pneumo, I don't know whether that strep pneumo originated in the lungs and is causing pneumonia, or did that strep pneumo originate in the throat or the mouth and just got picked up on the way out. So you've got to make that determination when you're looking at those culture plates. So all of those common causes of pneumonia, but also commonly found in the upper respiratory tract. And then these two, Pseudomonas and your other enteric bugs, your E. coli's, your Serratias. And really, we can even add in some other things here, like some stenos or things like that. Those are not really normal flora, at least not to any great quantity in the upper respiratory tract, but they can be transient flora, especially in patients who are sick. When you are sick, you tend to become more heavily colonized by gram-negative rods in the upper respiratory tract. And certainly when you're in the hospital, some of those gram-negative rods can be mean boys, like Pseudomonas aeruginosa or some of those. So even the isolation of these guys from a sputum specimen does not necessarily mean that that is the cause of pneumonia. So we have to look at some ways to try to make a sputum culture better. And solution number 1 relies on the people who are involved in helping to collect these specimens. Good patient education. You've got to explain to the patient, sputum originates in the lungs. You've got to have this deep cough that brings it up from the lungs. And then you have to minimize any contact with the upper respiratory mucosa. So deep cough, we prefer first thing in the morning, if that's possible to do. Rinse the mouth with water first, clean out as much of that normal flora as you can, but heaven's sakes, don't use any kind of antiseptic to do that, because that's going to mess up your entire sputum specimen. And this sounds kind of gross, but this is the way I kind of explain it. You want it up and out. Don't get something up from your lungs and then swish it around in your mouth. Okay, that's going to get way too much contamination. You don't want that. So that's going to be the key thing. And I can really say that that's kind of the key thing for almost all microbiology cultures. Good specimen collection and transport to the lab. Solution number 2 happens once we get it in the laboratory. We have to make sure that it actually is of lower respiratory origin and not upper respiratory origin. So we always do on a sputum, I shouldn't say always, I'll give you a few exceptions coming up. We'll do a direct gram stain to look for specimen acceptability. Here's the deal. If you have pneumonia, and this specimen is from the site of that pneumonia, you're going to have active acute inflammation. We're going to see a lot of neutrophils. Now, in a gram stain, I won't be able to specifically say that these are neutrophils, but I'll be able to see lots of polymorphonuclear white blood cells. That indicates this is a site of active acute inflammation, and that's a good thing. Squamous epithelial cells are from the upper respiratory tract. You don't have squamous epithelial cells in your lower respiratory tract. So if I see lots of squamous epithelial cells, that means there's contamination with the upper respiratory tract, and we are going to reject that specimen. Now, different laboratories will have different criteria. Some do a fancy little scoring thing with the number of white cells and the number of epithelial cells and kind of move that all around. We don't do that here. I don't count white blood cells at all, because if you have a patient who just doesn't have a good response, who's very low on white blood cells, they may not be able to provide evidence of active inflammation. The key thing is those epithelial cells. So if we do a gram stain and in a low power field under the scope, we see more than 10 squamous epithelial cells, we reject that specimen. We say this is too heavily contaminated with the upper respiratory tract, and therefore we won't be able to adequately interpret the results of the culture. We would look at it and say, here's Kleb pneumo growing, but I can't tell if that Kleb pneumo is from the upper tract or the lower tract. Now, there are some we don't do. We don't do pediatrics. There are some in pediatrics that we should reject, but we don't. We don't do cystic fibrosis. And we don't really care so much if it's for a fungal culture or an AFB culture, or if it's a test for one of these, what we call atypical pneumonias. Those bugs that aren't going to grow in culture, if we're going to do testing for those, we won't reject those because those really are not ever considered normal flora. So if we find it, then it's important. So here's a couple of very straightforward examples. It's rarely this obvious, but this one is beautiful. This one's got lots of white blood cells in it. You definitely have a predominant bacterial morphotype here, these gram-positive diplococci. You can tell right at the bat here that this guy's got strep pneumo. This is nice, beautiful inflammation. There's no squamous epithelial cells. And you've got this bacteria here that's pretty obvious what that is. So that one is yes, that's good. We're going to culture that one. This one over here is terrible. You can see all of these big, squarish, squamous epithelial cells. I don't see any white blood cells. And tons of bacteria. You may think this looks absolutely gross, but this is what your mouth looks like. You know, if you just did a swab of the inside of your mouth and we did a gram stain on it, this is exactly what you'd see. So this is a very definitely no way. Most of the ones that we get are somewhere in between, so it can be a little tricky sometimes. But the idea is that if there's too much upper respiratory tract contamination, too many squamous epithelial cells, we're not going to be able to adequately interpret what grows on the plate. I threw this one in here just because I thought it was really cool. I found this, Googling somewhere. Lots of nice white blood cells and these gram-positive rods here. Very dipteroid appearance. These little arrangements like this. This is a Corynebacterium, which normally, as I will show you in the slide coming up, normally we would kind of blow off as respiratory flora. But with this much inflammation, no squamous epithelial cells, and that thing right there, and single morphotype of gram-positive rod, that's going to be clinically significant. Solution number 3 comes when we actually have the culture plates to look at. Carefully interpreting those culture results. We need to look at it and see what is growing Is it upper respiratory flora or did it come from the lungs? And theoretically, we've already kind of dumped those ones that have too much upper respiratory flora, so it should be made a little easier. So I'm going to give you an example here. This is the procedure that we use here. Other places will be a little different. Every laboratory will have their own kind of way of doing things, but this is kind of like the main table that we have in our lower respiratory culture procedure. We'll start with the easy part. Over here on the right side, these are what I call special pathogens. These bugs, we don't care what quantity is there. If we see these bugs on a sputum culture, it is going to get reported. If you have one colony of a group A strep that we can figure out that it's a group A strep, then that gets reported. These bugs are not normal flora, or we're not going to consider them normal flora. Over on the left side, these are normal flora bugs that generally do not cause lower respiratory disease. You don't see micrococcus causing pneumonia. You don't see a Neisseria flavescens or some other normal flora Neisseria strain that causes pneumonia. So when we see these, that's normal flora, period, no problem. We're not going to report those by name. I'm not going to tell you that we got Eikenella from that, because if we report it, someone's going to try to kill it. Okay, so we don't do that. Here's this dipteroid here, for example, earlier, that beautiful gram stain. This is a situation where we would probably consider that Corynebacterium to be clinically significant just on the basis of the gram stain. These are the hard ones here in the middle. These are all bugs that commonly cause, or I should say commonly, but occasionally cause pneumonia, but are also normal flora strains. So our rule is report and perform appropriate susceptibility testing on up to 2 of these organisms, but only if they're in quantity on the plate or in the gram stain greater than the normal flora. So if I have moderate growth of a coagulative staph and light growth of a Haemophilus influenza, I'm not going to report the Haemophilus influenza because it's mixed in with the normal flora. But if I have heavy Haemophilus influenza and light coagulative staph, then the Haemophilus influenza gets reported. It's higher than the normal flora strains. So we're kind of using the normal flora as a baseline level of how much upper respiratory contamination is in the specimen. If this is a good specimen from the lung, then any pathogen should be there in a higher amount. So I'm going to give you some examples here. I'm not going to expect you guys to yell out what you think these are here, but these are our 3 plates, a blood agar, a chocolate agar, and a McConkey agar plate that we streak sputums out onto. And this guy right here, you're looking at these guys coming out here, but to tell you the truth, I'm not excited about those. I look at those and we can identify them in-house if we need to, but nothing here looks like a pathogen. This all looks like normal flora. So this culture actually got reported out as moderate growth normal respiratory flora, and that was the end of it. Nothing there looks suspicious for any causative agent of pneumonia. This one here also, there's this normal flora bugs in there. You can see these white colonies and little teeny tiny white colonies in there as well. But then you've got this gram-negative rod that is coming out, and it's actually in equal or slightly higher concentration than these normal flora bugs. This one would be a pretty easy one for us, especially if you could hold that plate up. And not that you do this, but if you've got the odor of this plate. This one was reported as light growth Pseudomonas aeruginosa and scant growth normal respiratory flora. So we decided that that was going to be clinically significant, and it may have to do also with what we saw in the gram stain. This one is tougher. This one kind of shows you how this can be kind of difficult sometimes. Because normally at first glance, I would look at that and say, this is all normal respiratory flora. I'm not excited about any of that. But this bug right here, the more whitish, opaquish ones, actually ended up being Staph aureus. Now, it is in equal concentration to the normal respiratory flora. Do we report the Staph aureus or not? I really don't have a good idea here about whether that Staph aureus is from the lung or is it up from the upper respiratory tract. And there's a judgment call there. And sometimes you look back at the gram stain and see what you see there, but Does that help sometimes? This one was actually reported as scant growth Staph aureus, scant growth normal respiratory flora. So definitely had to make a judgment call on that one. Don't know if it was the right one or not. This one, though, that was scant growth of Staph aureus that we considered clinically significant. Take a look at this dude. There's growth all over this plate. This is heavy growth, including at least 3 different gram-negative rods. This McConkey plate shows you at least 3 different gram-negative rods are growing down there. But otherwise, tons and tons of other things that are mixed in here. These are going to be some strep and some staph that are mixed in, some Corynebacterium perhaps. This is a kind of a big mess. So despite the fact that we had some gram-negative rods in there, this was reported out as heavy growth normal respiratory flora. Because these guys are not in higher concentration than these definite normal respiratory flora bugs. So this could be a situation where you had perhaps a colonized trach or something. Those gram-negative rods get glomped on there and you'll pick those up quite a bit. Or a situation where this is just a patient who is ill, and as a result, they're becoming more colonized with these gram-negative rods. Here's a cool one. This is a beautiful thing. I just had to show you this one. Nice heavy growth of these alpha hemolytic mucoid colonies. When we see that, we go straight to saying it's strep pneumo. Okay, now we can't tell for certain that it's strep pneumo, but we're going to identify that bug. And sure enough, he ended up being strep pneumo. Now there is normal respiratory flora in here. So we called it heavy growth strep pneumo, scant growth normal respiratory flora. This one is very straightforward. We're not concerned about this one at all. We got the answer right here without having to think too much. The cool thing about it is notice that there's no strep pneumo growing right here or right there. This patient is obviously being treated with antibiotics of some sort that are inhibiting the strep pneumo. So right here where the specimen was placed on the plate, there's too much of that drug left there and the strep pneumo is not growing. Now, there are some other bugs that crept through, including this little dry flat colony, which looks almost like a mold. You know, and remember, if you remember that table I showed you and have memorized the entire thing, you know we're going to report molds in any concentration. It's also showing up here on the McConkey plate, which is used for gram-negative rods. This is not a mold. It looks like a mold, but this is actually a gram-negative rod that's on drugs. So the antibiotics that this patient is taking is affecting this gram-negative rod. It's not killing it, it's just making it go wacko. So, you know, this is your gram-negative rods on drugs. That could very easily be like an E. coli or Kleb pneumo, looking very, very weird. Now, speaking of molds, this is one that can be tricky because we don't know. I hate molds. I'm sorry, I don't hate molds, but molds are very difficult sometimes because I look at this and I say, we have a mold growing here. It's scant growth. It might be moderate growth. It looks like there's like a couple that are popping up in here as well, but it's scant to light moderate growth of a mold, but heavy growth of normal respiratory flora. So this one gets reported. We called it moderate growth Aspergillus fumigatus, heavy growth normal respiratory flora. But the truth is there was so much upper respiratory flora here. I don't know if the mold is significant or not. And when we report that, I really have a problem reporting those because you look at it and say, you know, are we consigning this patient to a long-term treatment with antifungals with this? This is where the physician hopefully will really look at that and make a judgment of whether that aspergillus is something real or not. And let me give you an easy one to end up here. Normal respiratory flora up here, but on the chocolate plate, this bug is growing way out to the heavy side. So you've got a bug that grows on chocolate, does not grow on sheep blood. And if any of you remember that from your early micro days, that's heavy growth Haemophilus influenza and light growth normal respiratory flora. So that's a pretty easy one for us to do. So here's give you some examples of how we kind of go about it. There is another solution. Other specimen types. You can do a bronch wash, you can do a BAL, you can do a blood culture. Blood cultures used to be often recommended. They're not recommended that much anymore, but you may get lucky there with this. Human culture doesn't give us anything, but the blood culture does. The bronch washes and BALs are cultured quantitatively. We streak those out to get a colony count, just like you do with urine. And anything that's greater than 10 to the fourth colony-forming units per mil is considered clinically significant. That's by the book. But the truth is, I also look at normal flora there. These BALs especially, the bronch washing is not going to be good for bacterial pneumonia because it's going to have too much concentration, too much contamination with the upper respiratory tract. But it's okay if you're looking for a bug that's never normal flora, like a Legionella or a Mycoplasma. You shouldn't use a bronch wash for strep pneumo. A BAL, if it's collected well, shouldn't have hardly any contamination with the upper respiratory tract. They do sometimes. We'll gram stain those and see squamous epithelial cells and say, wow, somebody did not do a very good job of collecting this BAL. So even though we look at this and say it needs 10 to the fourth CFUs per mil to be considered clinically significant, if I have 10 to the fifth CFUs per mil of Staph aureus, but I have 10 to the sixth CFUs per mil of normal respiratory flora, then I still look at it and say that Staph aureus is not significant. So, what are the guidelines? These are guidelines for CAP, community-acquired pneumonia. And I have to put this in here because here are the arguments for actually doing a culture and trying to figure out what the cause of pneumonia is. You might get a resistant pathogen, which kind of falls down into this category here as well. You might need to adjust the therapy when they fail empiric therapy. So you might want to know what it is and what it's susceptible to. You may be able to narrow therapy. If you start them off on vancomycin, you may not be able to cut it down to something a little less harsh. There may be some public health implications. And I like this one down here because I am an epidemiology data geek myself. The constantly changing epidemiology of CAP requires ongoing evaluation. In other words, we need to know what's causing CAP. If we don't culture anybody, we'll never know what's really going on in the community. So, saying that, they then go on to this. In adults with CAP, should gram staining culture of lower respiratory secretions be obtained at the time of diagnosis? And their response is no. Unless the patient is in the hospital and it's severe CAP, or they're being empirically treated for MRSA or Pseudomonas, or they were treated with MRSA, previously infected with MRSA or Pseudomonas, or they've received parenteral antibiotics in the last 90 days. So in most cases of CAP, they're saying you really don't need. You treat empirically and let it go. So should you do a blood culture at the time of diagnosis? And their recommendation is exactly the same thing. So if your patient meets these criteria, do a sputum culture, do a blood culture. If they don't meet those criteria, then don't do anything. Treat empirically and then wait and see if it works here. These are the guidelines for hospital-acquired and ventilator-associated from the IDSA. Should patients with suspected VAP be treated based on results of invasive sampling with quantitative culture results? So should they get a quant BAL? No. They say don't do a quant BAL, do a trach aspirate culture, a non-invasive, a semi-quantitative culture. Don't do the quant BAL. If you do the quant BAL, should patients with suspected VAP whose culture results are below the diagnostic threshold, 10 to the fourth colony-forming units per mil, should they have their antibiotics withheld? And they said, well, if you do a quant culture and it was less than 10 to the fourth, then yes, withhold antibiotics. All right. Should treatment be guided by microbiology studies, or should you use empiric treatment? And of course, as a micro person, I say, of course, therapy should be guided by microbiological results. All right, let's end this up here. Now that I've gone through all that sputum culture stuff and said, this is more than I ever wanted to know about what goes on. Just a couple other things. There's a lot of bugs that won't grow on a routine bacterial culture. These are all bacteria, but they're not going to grow on a routine culture. So Legionella, there's a urine antigen test. The urine antigen tests are getting better. Most of the ones that are in use right now only detect one serogroup, the most common serogroup of one species of Legionella, but that is changing. There are new antigen tests that are on the market that are going to be broader. But really, PCR is the best. PCR is the way that really to do it. Mycoplasma, PCR is the best. There are serological assays, but serology, do PCR. Chlamydia pneumonia, the only thing you have is PCR. For TB, you really have to do AFB culture. The PCR is going to be better, but it is actually a requirement for us. If you order a TB PCR for the purpose of diagnosis, we must do culture as well. We need to try to get that isolate. Now, if you're doing a TB PCR to follow up, you already know this patient has tuberculosis and you're running PCRs because you want to see if it's still there, then you don't need a culture for that. But for the purposes of diagnosis, we must do an AFB culture, and we can add a TB PCR as well. So after telling you that we are not going to molecular or respiratory, lower respiratory pneumonia, there are big molecular panels that are out there to diagnose pneumonia. This is one of them, the one that comes from BioFire, the main manufacturer of these kind of things. It's pretty cool. It looks at these bugs right here. These bugs are really the ones that we just talked about as being potential pathogens that can also be upper respiratory flora. So it's going to do a semi-quantitative measurement of those. It's going to try to divide those up into different bins of approximately 10 to the 4th, approximately 10 to the 5th, approximately 10 to the 6th, or more, greater than or equal to 10 to the 7th CFUs per mil. That's the way they attempt to do that. So they attempt to do some quantification there. These ones down here, these atypical ones, there's no point quantifying those because they're not normal flora. They're going to be significant in any concentration that you get. And the same is true for viruses as well. The problem with this is we are not quantitating normal flora at all. I'm not quantitating those viridans, streps, and those co-native staphs that are always normal flora. So we don't know how this compares to normal flora. So you could, for example, we've evaluated this and saw the situation. You get 10 to the 4th club oxytocin. Is that clinically significant? Do we need to treat that patient? Well, I don't know. I don't know because is there 10 to the 5th normal respiratory flora in there? Is there 10 to the 6th normal respiratory flora? We don't know that. So that's the problem with these right now. One of the things you can do is you can treat this like a sputum culture. You can say if there's too many epithelial cells in there, then I'm going to reject the specimen. Or at least perhaps I'll report these guys and these viruses, but I'm not going to report these bacteria here. More useful for BAL specimens than they are for sputums. That's probably true because a BAL specimen, if it's well collected, should have less normal flora. And so these bins are going to be more clinically significant, more information on all there. So that's the end of it. Moral of the story here. Pneumonia is not really very simple. Finding the etiologic agent of bacterial pneumonia is not a very straightforward process. For most cases of community-acquired pneumonia, it's not really necessary that you try to find the cause of this case of pneumonia. The guidelines recommend that you really do not need to do that. You can treat empirically and then only do microbiological analysis if it's necessary further down the road. Culture remains the gold standard, but it's not really a very good standard. I'd call it an aluminum standard. I was trying to decide whether it should be aluminum standard or a lead standard, but it's not gold. It's not absolutely fantastic. It may give you results, but there's probably going to be a lot of times when you just can't interpret the results there. And these molecular panels, like in everything else in microbiology, these molecular panels are coming, but we need to have some studies to show how best we can utilize those panels without leading to overtreatment or misdiagnosis. So that is all I have for you today. Did I go too long? Not too bad. Sorry.
No,
I
you
was
did
going a little
great.
bit long.
As always. I know Dr. Ramirez is going to have lots of questions.
I know. I knew he was. I'm like, oh God, here we go.
Do we have comments or questions from the audience? I think
Just one person asked, what are some of the factors? I think on one of the initial slides that you showed, Alan, when you showed them the reduction in either cases and mortality among children. And she asked, what were some of the reasons behind this, do you think?
That's a good question. I can't really answer it really well. Notice that it did not happen in the United States. This was in other parts of the world where this really came down. So I would have to make a guess that it may well be more access in certain populations more access to healthcare than they've had in the past. I don't know, Dr. Ramirez, you got another
No,
option?
yes, you're right. More access with primarily with pneumococcal vaccines that we started with the
Mm,
conjugated 7, then the conjugated 10, then the conjugated 13. And this has been emphasis in vaccination in Africa now with the Gavi Foundation. And the pneumococcal vaccine has been a tremendous success in preventing meningitis and pneumonia in pediatric cases.
Probably hip vaccine as well.
yeah.
I think probably and perhaps even treatment of, especially in Africa, treatment of HIV. So when treating HIV, then the reduction of the pneumonia outcomes, especially in children that are infected with HIV. So yeah,
Am I flashing you guys?
you are.
I'm sorry. I don't mean to flash you all, but I don't know what's going on.
Like a highway sign. So what other, Dr. Ramirez, do you have any questions or comments?
Yes, I noticed what would be, because I noticed in one of your slides discussing etiology of pneumonia, they would say see paragraph below for enterococcus and yeast, but
Yeah.
then it was
But
below.
then I know I didn't put the whole thing in there for you.
No,
Yeah,
yes, but what would be your considerations then if in the sputum culture you have an enterococcus or in a sputum culture we get Candida albicans or some other Candida?
Yeah. Both of those can colonize the upper respiratory tract, but are extremely rare. And no one really wants to say they never cause pneumonia, but everyone always says they are extremely rare causes of pneumonia. So what we tend to do with those is we will, if we see it as the predominant organism on the plate, and it is the predominant organism in the gram stain, then we'll typically go ahead and report those. Most of the time, that's probably it's probably nothing. It's probably just upper respiratory flora that's hold on. What I've been told by nursing is when you get heavy growth of yeast, it is a sign of poor oral hygiene. I don't have any data to back that up myself, but that's what I've been told by nursing. So you look at yeast. Whenever we see a yeast on a sputum, we're going to identify it. We may not give you the result, but we're going to identify it to see whether it's a Cryptococcus or whether it's Candida auris. And those will get reported in any concentration. But if it's a Candida albicans, Candida parapsilosis, Candida kefir, those will only get reported if it is the #1 predominant bug and in both the plate and in the gram stain. Just because, and that's kind of a compromise situation there. There's microbiology guidelines that say don't ever report those. They don't cause respiratory disease. Don't cause lower respiratory disease. But then I think there are physicians who want to know if a patient is, it can give you some data as far as colonization as well.
Do you have any data or any perception if the patient has as you alluded, that the patient has a positive blood culture, then we assume that the patient has a positive blood culture for pneumococcal. We assume that it's pneumococcal pneumonia. Do you have any? Have you looked at the correlation that you have between what is found in the blood and what you report in the sputum locally? Do you have any? Have you seen totally their results or?
No, I haven't done any numbers to put it on paper. It's very commonplace when we have a good pneumonia, when I've had good pneumonia by a real pathogen, strep pneumo, to get it from both the sputum and the blood. That's common to happen. As far as when we get it from blood, but not the sputum, I have not specifically looked at those myself. but then you have to look at it and say, well, strep pneumo is also a common cause of sepsis, bacteremia, common cause of meningitis. There's other reasons besides the pneumonia for it to be in there. But so no, I don't have any data to share with you, but certainly we've seen situations as well where we have sputum cultures that give us normal flora, and then a blood culture that gives us strep pneumo. And in that situation, you're like, okay, it's strep pneumo.
Yeah. And you mentioned that using the biofire, the molecular technologies, you get a semi-quantitative result. You more or less somehow will give us a value of the how much bacteria is there, how is that the machine doing this semi-quantitative result? Is CT values? How is that?
Yeah, it's going to be based on, well, this is a biofire. So it's a little trickier because they do a nested PCR. But yes, they will have a CT value that they will calculate for each of those. So it's kind of like doing an HIV viral load, that is on a much smaller scale. It's not as accurate as that. But they can say, if we look at CT values that are in this range right here, and it might be on a biofire, it might be a CT value of 10 to 12 correlates to 10 to the fourth CFUs per mil when they've done their studies on those. You're not running a standard curve. You're not running quantitative controls with each of these. So it's not as controlled nearly as well as a viral load is. But just from the data that's been gathered in development of the test, they can look at it and say, CT values in this range typically are going to give you this concentration on the plate. So that's how they go about doing it.
And this pneumonia panel to do PCR, then what you recommend is always to do sputum culture, even if we order a pneumonia panel.
Well, you can't order the pneumonia panel with us because we don't do it. We decided not to do it because we thought it was going to lead to overtreatment.
Well, then you just mentioned in your presentation, but
I mentioned it because it's out there. It's coming. There's some other ones that are out there as well. We've actually evaluated a couple of these different pneumonia panels and decided not to use them. So no, here you can't order it. It's not available here. Now, if we did have it here, then I would still say you need to do a sputum culture. If you've decided it's important for us to figure out what is causing this case of pneumonia, then we need to get the bug, if possible, to get susceptibility testing done as well. That pneumonia panel has those, the VAN-A gene, the MEK-A gene, the ESBL genes, that kind of stuff. But if you don't get one of those bugs, then that's not really helpful at all. You're not going to get those results. So being a micro person, I'm an old micro person. So I'm kind of giving up culture very slowly, kind of hanging on to it as long as I can. And you've got these benefits of culture, which is being able to have that bug for susceptibility testing, and if necessary, to have that bug for epidemiological testing, which the molecular stuff is not going to give you. So yeah, if you said, I got a patient with pneumonia, I want to run that pneumonia panel, then I would say, okay, we'll run the pneumonia panel, but we're also going to do a culture.
There's another important part of microbiology in the management of pneumonia. That is, you get admitted to the hospital with pneumonia, or you develop pneumonia in the hospital. It's different forms of pneumonia, and there are all these guidelines for the management for empiric therapy. And then you have the subset of patients that fail empiric therapy, and then in 1-2 days, the patient that was on the ward now is going to the unit, or going 3 days, or the person now goes into a ventilator. And will you consider that at that point, when you already have your initial cocktail that is failing, do you consider that is at that point you go for another sputum culture, or we should go for the pneumonia PCR panel?
Well, in that situation, the pneumonia panel will have an advantage of picking up dead bugs. Okay, so if the treatment has killed the organism or inhibited their growth or injured them to the point where they're not going to grow very well on the plates, like that gram-negative rod that we saw on that one plate with the strep pneumo. If that's what happened, then the PCR panel is going to pick it up. Downside is that it's going to pick up the bug even if they're dead. So even if you have treated the pneumonia, but the patient is getting worse for some other reason, you're still going to pick up that bug. You know, so that's the problem with PCRs. They're good and they're bad. So it depends on when you say the patient is failing, the treatment is failing. Is the original organism causing pneumonia still causing infection? A culture would be able to tell you that, because the culture, you'll get the growth of the organism. The PCR wouldn't be able to tell you that because you're going to pick up dead organism anyway. You see, it's not simple. This is
microbiology is not simple, and this is why the management of all these patients is not simple.
Yeah.
I like what you mentioned that essentially, whatever you report, someone in Norton Healthcare will try to kill it.
Well, isn't that the case? You know,
this is very good. Whatever microbiology report, someone will try to kill it.
I think that's absolutely true, which is why we have all these complicated procedures of trying to only name the bugs that we think are clinically significant. You know.
Very good. Ruth, do we have any other comments or questions from the audience?
No, nothing else. I think that was just an excellent overview and great discussion, as always. So thank you very much.
Sorry, I'm flashing at you guys. How long have I been doing that? Has that been going on the whole time?
No, at the end, just at the end.
Oh, okay. Sorry about that.
Well, thank you, Alan. Thank you very much. Again, excellent presentation.
Right.
And thank you, all the participants.
I think next week we'll have someone from the Kentucky Department for Public Health giving us an overview of the reportable diseases. So I think this will be an excellent session. We're very appreciative that they will provide us with these updates. So we will see you next Wednesday.